Señoras y señores, muchas gracias para su presencia esta noche. Estamos haciendo una formación en directo con el doctor Javier Beut a propósito del tratamiento del midface, art filler y fine line con nuestros partenario Filorga. No se preocupen, se puede preguntar cualquier cosa que tendría sobre nuestro sitio web. Muchas gracias y hasta luego. Doctor, the floor is yours.
Thank you. Thank you for the invitation. I'm happy to be in Paris again. It's always a pleasure to work with some friends. So anyway, we have a patient. We need to. I want to show you what is my philosophy on to treat the midface. And if you play the algorithm, video, I will show to you, what I'm going to do on the patient. So the most important thing I do is I never, as a surgeon, we like to make drawings. It's something that we cannot miss. And every time we do something on the face, we want to make standard techniques. So for that, what I do is I place the first thing I place is the midfiltrum. Then I place, the lateral canthus, as you can see here. Then, very important, 1 centimeter from the nostril, I make what I call the equator line, like this. Then, 45 degrees from the internal canthus, I make, a line like this. And then what I do is I divide the lateral part with a long line. And finally, I joint the canthus with, the philtrum. So why I have divided the lateral part? Because if you look to the anatomy, all this part is run by masticatory muscles. We have the masseter muscle and we have the temporalis muscle, but no mimetic muscles. So this part is not mimetic. The only part who is mimetic and link is the frontalis with the midface and with the lower face, with the lip. So it's platysma muscle, orbicularis, zygomaticals, Orbicularis, oculi, and frontalis. So when the patient smiles, can you smile please? You see everything here moves. So everything is linked. So that's why it's so important, to think about mimetic muscles and masticatory muscles. So that's why we make these divisions. Then, when we do the analysis of the face, we have, at the midface, we have 6 fat pads. We have three deep fat pads that is called the deep mid fat pad, the medial sousp, and the lateral sousp or pre-zygomatic space. The pre-zygomatic space is run up to this region. This has been developed or, not discovered, but more, this is a scientific paper run by Dr. Mendelsohn from Australia, where he has, demonstrated, all the spaces we have in our face. We have the pretemporal space, we have the pre-zygomatic space, we have the pre-massetary space, and we have the pre-maxillary spaces. All these spaces are without any vessel, nerve, are empty spaces. But they are spaces. So whatever you inject in these spaces will stay covered, and because we have different layers that won't leave this product goes or spread or have some kind of migration. Then we have superficial fat pads, and then we have the nasolabial fat pad, the mid-cheek fat pad, and then we have what I call the inferior fat pad. So if if you look to the, can we show the the anatomy on the video? It would be possible, on the second video. Is it? Because on the second video, I want to show you something very important. We have the deep fat pads. They are linked. No. This one. If you look to this pertinent anatomy, let me show you what happened. As you can see, these are the three, these are the fat components of the cheek. And we have, as I said before, three important deep structures that are the mid cheek fat pad, we have the mid tooth, and we have the lateral tooth. What happened is these fat pads are over what we call over the bone. They don't move. Those that move are the superficial ones. So what happened is when the patient smiles, we have what we call the Daleiden effect. That means that the superficial fat pads glide over the deep fat pads. So that's why it's so important to make the analysis of what kind of fat is missing. Because when the patient, if these are, the deep fat pads, and then we have the superficial fat pads, as you will see again on the video, they will glide over. They will glide over superficial, over the deep. And then, why is so important this? When you do, for example, when you do the, you use fat, it's not so important. Why? Because fat has more or less the same, texture. But when you use fillers with different particles or cohesivity, then is when you can have, a problem. You cannot inject superficially, a big particle size, because you're going to have like a lifting effect. Imagine, from a point of view, if I use a cheek prosthesis, a silicone cheek prosthesis to enhance my cheeks, and then I place over the skin. So every time I will smile, I will see my cheek coming up and down. This is horrible. So the thing is, when we need to give support to the patient, what happens is we have to go on a deep aspect. And this won't move. When we need to have animation, then we need to work over the superficial fat pads. Using fillers, what we do is we use large particle size fillers or different cohesivity fillers on a deep aspect, and the minor particle size and minor cohesivity on a superficial one. So that's why it's so important to understand when to do it, what, how, and that's the key of this technique. So another important thing I want to mention is I don't use needles for that, because needles do not respect layers. I know, as we have a very famous plastic surgeons, around the world, that they like to do, these injections, all around. But if you are honest with me, what happened is, maybe you can say, yes, I touched the bone, but when you move the needle up, some of this product is coming up, always, even if you are the best injector in the world. So that's why this is the first reason. The second one is, when you use a cannula, what happened with the cannula, if you are not on the right space, you won't go. So that's why it's so important to use cannulas, because you're going to respect all these layers. I'm going to use some local anesthesia, because I like to use some local anesthesia to my patients, always. May I have some gloves? Okay, here. No, it's okay, no? Ils sont trop petits, no? Oh. They gave me French gloves. I was asking for Spanish gloves. Sorry. Maintenant, vous pouvez vous allonger un petit peu. Ouais. Ah, non, comme ça va? Oui, comme ça va. Sinon, ça va. It's okay.
Dr. Beut, I might interrupt you for a second. We were discussing a bit earlier, and you were mentioning a mnemotechnic way to remember all this kind of thing with these famous 4 letters. Maybe can you give a hint to our audience? What is this mnemotechnic thing?
So, is the first, c'est un peu d'anesthésie locale. Hein? Let me place some of the anesthesia. I always like to use some local anesthesia with the epinephrine for different reasons. I will ask you the question immediately I finish. Because the first thing is I like to minimize, pain. And another important thing, I want to minimize, bleeding. One of the biggest dangers, on doing fillers is embolism. So I know that I don't know, I'm going to use cannulas, I'm not going to use needles, but anyway, I like to have some kind of vasoconstriction in the area where I'm going to inject. Just for demonstrations, I like to I'm going to go to the zygomaticofacial nerve, I go down to the bone, just a few drops, and then I will have just this region completely numb. Perfect. And then down to the zygomaticofacial nerve. This is the most, and that's it. You can hold this like this, just to press a little bit. Perfect. So I have just used, less than 1 mile for the anesthesia. We have to wait a little bit just to obtain, the whitening of the skin. That this will be, the effect of the adrenaline. And another very important thing that I want to mention is the following. My philosophy is not to fill holes. This is very important because when the patient comes to our offices, they say, "Doctor, I don't like my nasolabial fold." And 80% of the standard procedure is just to fill the nasolabial fold. But why we have nasolabial folds? We have nasolabial folds because it's a natural sulcus. Since we are babies, we have natural sulcus, nasolabials. The problem is as we age, as we age, and we have deflation of the skin in this region due to the fat, this becomes more evident. So what we have to do first is not to treat the nasolabial fold, but to give tension to the midface. Where? On a spatial location. All right? So that's... No, ici. No, ici un petit peu ici. Okay, this is very important. So do not fill holes, give support to the face. So when you do your analysis, what you have to do is to understand why this nasolabial fold or fold appear. Another important point in this patient are the tear trough of the junction between the lid and the cheek. I like not to fill again this gap because this gap is due to the following. We have the lid, we have the cheek, and what happens is we have certain ligaments. I'm not going to go through this because it would take 3 hours, but they detach, and what happens is the lid and the cheek has been separated. And one of the things you have to do with your patient, you ask your patient to smile, and when the patient smiles, she corrects or he corrects, her lid-cheek junction. So how I do treat this? I don't like to treat like feeling, the whole tear trough, but instead of this, I like to blend it, to blend the lid and the cheek. And how I blend it? I blend it. Ça c'est quoi? Volume. Okay, je prends ça. It's just I'm not going to inject. C'est seulement je vais montrer. Okay. So what I'm going to do on her, if you can you zoom to the. So I'm going to go to the place where it's knitted. Okay, from inside. And then I'm going to leave a drop, and then down, a drop and down, a drop and down. So what I'm doing here is I'm filling in certain ways the tear trough, but at the same time I'm adding some volume to the upper part of the nasolabial fold that, remember, is a superficial fat pad, this one. So I'm not filling the tear trough. I'm just blending the lid and the cheek. And another very important thing, when you do this, what happens is you go against the vector of the orbicularis. The orbicularis oculi muscle has three parts. It's the pretarsal muscle, the preseptal muscle, and the orbitalis. So this is where the orbicularis muscle has its insertion. If you look to many textbooks, you will see that they call a sphincter muscle. And it's not a sphincter muscle. It has insertions at the medial aspect of the orbit. So if instead that to inject, as I said, opposite to the vector of the orbicularis, I inject following the vector of the orbicularis, I'm increasing, how to say that in English, like the negativity. I'm giving, a heavy face. Because what I want to do is not to increase the vectors of the orbicularis, but I want to go against. All right? So now we have already anesthesia. So the patient, now this is just the bolus. What she needs, if you look carefully to her, she has a depression in this region, as you can see here. This is the bolus of the anesthesia. And this is the deep mid-fat pad. So she needs a small amount more on the left side than on the right side. So I'm going to use universal for that. So, maintenant tu me donnes cette aiguille. Touchez pas, non, touchez pas. Non. Ouais, tu avais touché ici un petit peu. I care a lot for, for any contamination. So, tourne un petit peu comme ça. I'm just, ça c'est quoi? Universel? Parfait.
Doctor, can you give us a hint on why it's difficult and how you manage difficulties using the cannulas?
Why cannulas?
It can be difficult and how you manage the difficulties of the cannula.
The cannulas, if you know the anatomy, they are very easy to use it. If you don't know the anatomy, then then is why needle is more standard. Why? Because as I will show you now, if I'm not on the right place, the cannula doesn't go through. But I will know that I'll be at the place where I want to be.
Okay, so better to use the cannula in that instance.
And another important thing, one of the worst reports we have is blindness.
Not good.
Or, some kind of necrosis of the tip, or the skin of the nose. When you use these tiny needles and you go superficially, you can be so unlucky to give an embolism.
Yeah.
So that's why, when I have a patient that comes to my office just to do some small injections and he leaves my office with a blind eye, that is not the case. So if you make a balance, what to do, I live this out.
So you're basically reducing risk using the cannula.
Absolutely.
Okay.
One is reduce the risk, and second, I know where I am for, I'm injecting on the right place. Absolutely.
Okay, that's very clear. Thank you, Beut.
Tu m'aides un peu, tu m'enlèves, parce que après on voit pas le, tu m'envoies l'aiguille. Okay, so now I'm going to inject above the equator line. All right, I'm sorry for that. The patient says how, because we are on the bone. All right, but why I'm doing this? The first thing is because this is the premaxillary space. All right, and injecting into the premaxillary space is an empty space, remember. I'm just giving some volume, and giving this small amount of volume, even if she doesn't have edema already, but we can see that the nasolabial fold already, diminished. I don't want to say disappeared, but diminished because I have added volume to this region.
Dr.
Now,
Beut, can you just give us the size of the cannula? It's a question from the web.
This is 23.
23.
23.
Okay.
Okay.
Very clear. Thanks.
Okay, now, because I have already injected into the deep aspect, at the deep mid-fat pad, I'm going to go up to the tear trough with a 25 cannula using the fine lines. 25. So, when you do this, remember, I don't know if you see the face of the patient that when I touch her bone, she moves a little bit because it's not pain, but it's discomfort. But really now, everything here has been anesthetized because Universal has some lidocaine. So when I'm going through now, she won't feel any pain. So when I'm going through, my space, the premaxillary space to treat, the tear trough, I'm going to ask my patients to upgaze, and then, as you can see, when she looks up, you see the sulcus is much more evident. And you know why it's more evident? It's due to the fact that the arcus marginalis is based with the orbital septum, and it's where, when you raise up your eyelids, you put on the traction. This is a technique we use as a photograph. We use surgeons, to analyze how much fat our patient has, retroseptal fat pad. So when the patient looks up, this is really much more evident, and then we can see, the gap between the lid and the cheek. If you look carefully to this side, because I have already injected, look how different, a little bit different is this side here. It looks more empty because I did nothing. So that's why first step, deep mid-fat pad, and second step, I'm going to the tear trough. So I'm going with my cannula. Always check, if not air, some product is coming out. Oui. Okay. You see, now I have touched her bone and she didn't feel anything. Now I'm going to see up like this, and you see my cannula is going to, you see, it has nothing. I mean, she doesn't find any resistance. But if I go more superficially, she doesn't go through. And because I have a cannula, of course, I can go through, but then I'm going to give, a big hematoma or pain to my patient. So what I do, I go down again, and then you can see my cannula now is going up. So then I place my finger, sorry for this, because these are French gloves and not Spanish gloves. So, and then I place my finger over the orbit, and then what I'm doing, I'm going to, you see this maneuver, I'm going to lift, you see, my ligaments. And then you see the cannula? And then I leave a drop and down. Now again here. I'm over the bone. I want to raise I feel like a plop. These are the ligaments. I leave a drop and down. Now again here. You have to feel, if you see resistance, you can lift up like this, no problem, but be gentle. Always your finger. And down. And then you do some massage. Ça va?
Dr. Beut, we have a question from the web. What quantity did you just inject?
Look, I'm doing this. This and this. This and this. I cannot measure it almost. Maybe 0.1.
0.1. Okay.
Nothing.
Okay, almost nothing. Thank you very much.
Dis-moi. Now, if you look from above, again, you see that this is start disappear. You see?
We have a question from Peru asking what are the angles of injection that you use for the cannula?
Angles?
Yeah, what's pent 1 degrees?
Okay.
A rough idea. I'm not going to measure it.
Anyway, so when I'm, from Peru, if you come close to the camera, when I reach, this region, I'm over the bone. You see, over the bone. And then I lift up a little bit, but do screw motion, like this. And then suddenly you feel plop. And when you feel that plop, is you are through the ligaments. All right? Ouais, on sait ça. Ils sont les gants. Ouais, après les gants, j'ai la main mouillée. Ok. Comment ça, je peux faire là-dessus. Ok. Regardez en haut. So I'm going to work over this region here now. So again. I place my finger. If it doesn't go through, I lift up, you see? But always with my finger, because my finger, what it does, it blocks my cannula. My finger blocks my cannula. It doesn't allow my cannula go through the retroceptor space. That is horrible. Horrible because you can have a big edema. So remember, place your finger. So I place my finger here. My patient is looking up. I feel already the plop. And down. And now, remember a very important thing. Don't try to finish the case in just one session, because this is going to capture water. And what happened today is not what is going to happen tomorrow. All right? We don't know the reaction of our patients. Regardez en haut, en bas. And then, if you look carefully, si vous asseyez un petit peu. Regardez, if you look to the patient, okay, if you look carefully, what was before just like a circle now has become more straight, just with some drops. Come closer, please. Un peu plus près, s'il vous plaît. Non, pas moi. Moi, je suis... non, ici. Plus. Okay, arrêtez. So if you look carefully, this you see the gap here, and then this has become more vertical. So when you reach this region, or this level, is when I always said to stop, and then I move to the other side. Down.
Doctor Beut, ¿se puede preguntar una cosa del internet de Argentina? Y sí. Yo voy a traducir en inglés también. ¿Cuánto tiempo se queda el producto? How long does the product last?
I speak in Spanish or in...
As you wish. You're about trilingual. Para Argentina, en español.
El producto en esta zona de aquí dura mucho si lo colocas en el sitio adecuado. The product, lives, it's long-lasting, result.
If you put it in the right zone.
In the right place. What happens most of the time is patients, the easiest way, as I see, is to do this. You go with the cannula, and you go through like this, and you inject. This is what I call, if you have a fibrosis thing, I call the banana space. Because when the patient will smile, if this has a fibrosis, she will going to have like a banana. It's going to have we call this banana effect, It's horrible. So the patient smiles, and then you suddenly see something coming out. So that's why I hate to do just this. That's why I love to blend this, doing this, drops like this. All right, it's more natural.
Gracias.
De nada. Y viva Argentina. Aunque Messi fallara el penalti. Okay, are you okay? Okay, ça va. So I'm going to give her just a little bit of, just a tiny volume of, universel? It's universal, no? Universal. So this is what I call type 1. Then I'm going to give just a small amount, all right. So this region here is what we call the projection area or the support area. It's the same area because we have the zygomatic space or lateral SUF and the infraorbital fat pad or superficial. So if you want to give support or projection, then you have to go down. If you want to give some volume, you can go more superficial. So I'm going to use universal, and then what I'm going to use, I'm going to do this way, if the cannula allows. Give me the needle. No, l'aiguille.
Doctor, what are the edema risks as far as the superficial injections?
This is a very good question.
Argentina as well.
Argentina is...
And Messi.
As we know, this region is lack of lymphatics. So one of the problems is you inject too much in this region superficially, you can have, edema, because we don't have drainage. So my idea is always to go deep, and where I go deep. You see, I'm crossing the face, and I'm going to be now. I'm over the bone. You see here, I'm over the bone. So I'm going now. If you keep attention, you're going to feel my cannula. I'm over the bone. All right. You feel my cannula doing like a clack. All right. Keep attention. Clock. I cannot repeat it again. So I hope you got it. So I'm in the pre-zygomatic space, and I know that whatever I inject in this region, it will stay, because this region is covered by is a natural space. So what I have injected is just to give some support to my patient. I have used universal. I did not use volume. I just used universal. So if my patient will need more support, then I will use deep, as I did, but with more, a bigger filler, and then I use just universal.
Spain is back in the game.
Is it Spain?
Yeah, Spain. Is there any risk with this procedure of a Tyndall effect?
Tyndall effect with this? Absolutely not. Because as you can see, I'm very deep.
Okay.
I'm very deep.
That's very clear.
Okay, so
Thank you very much.
No. Regardez en haut. So now I'm going to just blend a little bit with art filler. C'est fine lines? Fine lines. Non, volume, non. Fine lines. C'est bien. Très bien. Ça vous plaît, oui. C'est fine lines, no? So what I'm doing now, because I have treated zone 1, I have treated this region 2, and then I have given some, as you saw, some support to the cheek, very deep. What I'm going to do is I'm going to blend not anymore the lid and the cheek, but the 3 superficial fat pads, the nasolabial fat pad, the cheek fat pad, and the infraorbital fat pad. And then how I do that? As you know, most of the time, when we have the nasojewel groove, the nasojewel groove appears, and her case is visible now here, all right? So the nasojewel groove is where by the way, where we have the facial vein. Standard procedures, what they do is they enter from this part, they go down to the trough, and then they go down and they inject like this. Again, this is to fill a hole. When the patient, if you have any fibrosis, every time the patient will smile, you can have a cord here. So my suggestion to blend, the 3 superficial fat pads, I'm going down. I find my hole. I do pinch and pull. I pinch my superficial fat pads, and then I go through like this, so easy, as you can see. And then I do like I call this the Parkinson technique, like this. And then I blend the three fat pads.
Doctor, with such technique, can you inject the internal palpebral muscle?
Internal palpebral muscle?
Yeah.
Which is this muscle?
It's below the eyebrow.
Me?
Below the eye?
Below the eye.
Yeah.
Okay. So, below the eye we have what we call this is the Orbicularis oculi muscle. Okay. And the Orbicularis oculi muscle is divided in three: pretarsal, preseptal, and orbital. I'm below that.
Okay. Okay, that's very clear. Thank you.
So what the tarsal, are you okay? Ça va? No. The tarsal muscle is a muscle, regardez en haut, is a muscle we have in this region, and it's linked what we call the capsulopalpebral fascia, and it's a retractor muscle.
Okay.
It's the one when you read, you are on your, if the camera looks at me, we are on your bed, reading with your iPad, and you're trying to look down, like this, with your eye looking down. It is a retractor.
Okay.
All right?
Okay.
But I don't touch this because this is in this region. This is on the tarsal plate.
Okay.
Not in this region.
Okay.
All right?
That's clear. Thanks.
I want to mention, because this is not clear, this region, we sometimes say, you are injecting into the Trough. Let me tell you where I inject this very deep. Because I have many doctors and clever doctors, watching this, this operation. Let me show you what are the different layers. We have the bone. We have what we call the pre-periosteal fat, not the Trough, the pre-periosteal fat. Then we have the prezygomatic space with its capsule. Then we have the Trough. Then we have the orbicularis muscle. Then we have the infraorbital fat path superficially, and finally we have the skin. So between the bone and the muscle, we have some fat, and we have this prezygomatic space. It's clear? In this region. So if I inject into the prezygomatic space, because I'm going to feel it, because I'm going to, with the cannula, not with the needle, because with the needle I won't feel anything. I'm going to feel like I go through something, then I know I'm in a natural space, and the most important thing is that the product won't move. All right? So anatomy is the key. Okay, so je vais faire l'autre côté aussi, hein. Alors, if you want, tu vas le...
Doctor, is there a risk to touch the intraorbital artery in that case with that
there's
procedure?
Always risk. There's always risk if you don't know where you know what. That's why, in my academy in Mallorca, I like always to explain something very, very important. I like always to compare with sports. If you go to play tennis, if you go to play golf, and you see your teacher, doing, very nice swing, you say, I want to do that. But you see how he does, but until you don't touch the ball, your hand, and you have a new synapses, you don't know where you are or what you do. So this is the same thing here. The thing is, you can do, anatomic cadaver dissections, but the most important thing, as you can see, I didn't watch where was my cannula. I was feeling it because I knew where I was. So, if I know that this is a prezygomatic space, is empty, if I'm in this space, I know where is the infraorbital nerve. It's 10 millimeters, 11 millimeters from the infraorbital rim, here, at the pupil, in this region. Of course I can go through if I'm, an animal, talking in like we say in Spain, no, un animal, no? But I will never, if I'm going down here because it's the maxillary space, then go through because I know is the pedicle of the infraorbital nerve. So of course you can touch it, but remember, if you look for the arteries, they are superficially. If you go down, you won't touch these arteries.
Okay.
All right?
All right. I'm just going to ask our patients tonight, how are you feeling so far?
I'm feeling good. I'm feeling well.
You're feeling well?
Yes, I hope to see the result.
Soon. Me too. Maybe we can have a very quick comment at mid-space between the left and the right part of the face.
You want to?
Yeah, you can have a quick comment on that.
I mean, si vous asseyez, comme ça. So, if you look carefully, non, regardez là-bas. Ok, comme ça. Who's touching? C'était moi qui touchais? Oui. Si vous tombez maintenant comme ça, alors il faut refaire tout. So, if you come close to the camera, please. Okay. So the thing is, smile. Alors ça c'est la chose importante. This is the important thing. I mean, when the patient smiles, I don't want to see any irregularity. You see, smile. Souriez, et refaites comme ça. Non mais regardez la caméra. Un peu plus près, s'il vous plaît. Closer, please. Closer. Un peu plus closer. Lo digo en español, más cerca, por favor. Así, regardez, ok. Normal, ok, parfait. So if you look, this is nothing to do with the injection. Remember, this is the anesthesia, all right? But regardez en haut, look up, regardez en haut. Mais c'est pas très, ok. You see the slight difference you see between this and this. The patient doesn't want to change too much. I don't want to make, a mask on her face. I just to blend, the regions. Regardez en haut. You see the difference between this and this? And remember, this is going to capture water. So tomorrow it won't be like this. It won't be a little bit bigger. So be careful on that. So I think maybe I do some, refinement at the end, but before I want to finish the right side.
Thank you a lot, Doctor. We've been a bit quick on the time, okay. So we will go on to the Q&A session.
Okay.
We'll come back with you in a few moments. Thanks a lot, everybody. Please stay on the line. We'll be back in a few seconds for the Q&A and trying to answer any of the questions you would have, and you can ask on our website. Thanks, and see you in a few seconds. Thanks a lot for bearing with us tonight. So we are back on the second part of our Tonight Live show. Remember that you can ask any question that you would have. Live chat, www.cib-formation.com. Back with Dr. Beut. Thanks a lot for bearing with us and our patient. So first, I will start asking our patient how does she feels and how did she feel during the treatment.
En français?
Oui,
en français.
Presque imperceptible. Voilà, ça se traduit par des petites décharges électriques lorsqu'on bascule la canule à l'intérieur de la peau du muscle, mais largement supportable.
Okay, quick translation. Almost imperceptible. Very, very light feeling when the cannula is going a bit deeper, but basically very easy to leave. Thanks a lot. So, Doctor, you have a few hints and a few videos that you would like to show us on the technique.
The first one I want to show, when I treat the patient doing, the Trough, this is what we call on our scientific paper published on the Gold Journal, is type 1. If we can see that video, then we'll really realize, where the cannula goes. Show the video. Okay, you see the video, and then I go with the cannula, you see, and then we go into the levator labii superioris and the nasolabial fat pad. Then we cross the ligaments, as you can see. Then we leave a drop, and then this drop comes down, and that's why we joined you know, the lid and the cheek, but we don't feel the tear trough. It's just a matter of
and the diminished volume
area.
of the deep
it's not really to feel
medial
the tear trough. The tear trough is in conjunction with the upper part of the nasolabial fold. So it's just this. It's a matter of blending, you know, to these two areas.
Okay, maybe we would seize the opportunity to come back on the very small mnemotechnic 4 letters that we mentioned together earlier for our audience. I think it's of much use.
As we talked before, I mean, it's like when you go to the web explorer, you know, and it's H, it would be how, then when, what, and to the who, you know, the person. So these are 3 very important, you know, the type of the anatomy, the type of product, the type of patient, and the type of product. This is very important because you can be the best injector, the best surgeon, but if you don't know the product, it doesn't work.
So a reminder for everybody, HWWW, your technique, homemade. Thank you very much.
Yes.
So, can you just make us a very quick recap on the products that you use, where and how, very quickly to have a takeaway reminder?
I have used only two products. I use Universal and I use Fine Lines. Universal is more dense and I mean, I want to do just a small parenthesis on that. You know, when you see all the, you know, the laboratories, you know, with these templates about you have to inject into the mid-dermis and the I want to ask to all the audience, who's capable to inject into the mid-dermis? None. So my concept is the Daleiden effect. So depending on the kind of particles we have, we're going to have a different type of lifting. So how much do I need to lift in this region where the thickness is 4 millimeters? Just few. So I don't need, you know, a large particle size. I'm going to use, you know, in that case, fine lines. So because I know fine lines is a skin booster too. But if you inject, you know, fine lines in this region, of course you're going to have some matter of, you know, of lifting of the face. So you can obtain the same result with a drop of the tear trough.
From Argentina, ¿puedes recordarnos las diferencias técnicas entre los diferentes productos? What are the difference, technical and constitutive difference between the products?
The thing is, it's not a matter of different techniques for different products. Is to use the product where it's needed. I mean, if I need, I mean, it's depending on how much I need. I mean, imagine, you know, I need a deep mid-fat pad because this is empty. So I'm not going to use fine lines because I need hundreds of tones to lift that. But just with few drops of Universal and sometimes volume, then I'm going to obtain result because I need to lift more. But when I'm treating, you know, when I try to blend this lid cheek or the folds in this region, I don't need to fill. The only need I need is a filler that will help me to communicate, to blend all the regions. It's a matter of...
We are going along again on the World Cup World Tour.
Merci.
Britain is asking, what kind of other techniques can you use to complete and follow up on the results?
I mean, to complete the results, I mean, using fillers. I mean, it's true that when I ask my patient to come 10 days later, you know, and look into the, you know, to the lid and cheek, and I see a small depression. Of course, I'm not going to use a cannula going through. Then maybe I'm going to use a needle going down to the bone and lift a small amount to the bone, and then a small drop coming up, just to do the refinements. You know, very small things. But to give volume, to give, you know, shape, I will never use, you know, my needles. It's like when you do temple.
Yeah.
The temple I use from this part with my cannula, and then what I do is I go between the superficial and the deep temporal fascia. This is space. There's no vessels, no arteries, and then you can feel whatever you want with no arm.
Genuine question from my side. Would you use the same techniques either for male or female patients?
I mean,
okay, no difference.
It's the same technique but different products.
Okay.
Because you have heavy, thick skin. then the skin of the, it's like a Caucasian or Asian.
Yeah.
I'm going to use the same technique but with a different product.
Okay. Maybe we can make a very quick wrap-up on the tool that you showed us a bit earlier today, this application on the anatomy analysis, and show it quickly to the audience.
If they go to the, where you can...
take out the volume.
Pop up the volume. Let me because I was touching this. Okay. So if you go, it's free for all the participants to this symposium. You can go and then you can see absolutely you're touching, with your finger. This is an application we have created with Dr. Jelks. This is my partner in New York, and then. If you look, I can absolutely, remove, muscles. I can absolutely, touch whatever I want. And the most important thing, if you look to the fat pads, let me do like this. I can see the fat pad. If I touch here, for example, you see, this fat pad is coming out. If I touch this one, this fat pad's coming out. So I can enlarge, I can see. And then it's very useful for the anatomy.
Very, very useful application. So, Beut and Jelks, it's called oculoplasty.
Oculoplasty.
And we are having a special offer tonight. The application is for free for all the live web attendees. For 1 week.
For 1 week.
For 1 week. Thank you very much. I have another question. How do you manage and prevent potential complications? And what are the main risks to such treatment?
The main risk for these treatments is embolism.
Okay.
This is the main risk. Because, as I said before, you cannot risk. A patient can understand, he has some kind of blindness or problem if he is under surgery.
Yeah.
Sometimes he understands, sometimes. But he will never understand a blindness or a necrosis on the tip just after a single injection of hyaluronic acid. So that's why if you go to the anatomy and you understand the anatomy, this is the most important thing. Not to go to teaching courses when they explain, how beautiful is the product.
Yeah.
Go to the anatomy, use the cannula, because as I showed you before, when I was on the right place, the cannula went through. But when I was superficially, it did not.
Yeah.
So that's the point. So you can have edema, you can have some hematomas, but this is standard.
Okay.
Even if you use cannulas, you can have, because, listen, you can use a cannula. The cannula doesn't harm because it's not sharp, but it depends on the hands. If you use the cannula like Lancelot, then you can have a lot of hematomas. But if you use, the hand like Leonardo da Vinci, then you won't have any hematomas.
Or Javier Beut.
No, I'm just Javier Beut. But another important thing, imagine that our patient is under treatment with aspirin or heart infarctus, and he's taking anticoagulant.
Yeah, for sure.
So sometimes they don't tell you nothing about that.
That's a risk.
Another important thing, some patients come to our offices where they have been injected before. And you know what I do? I don't treat these patients.
That's a good takeaway. We are almost at the end of the live show. For the worldwide audience that have been with you tonight.
A lot of Argentinians.
Yeah, I know. Three quick takeaways before leaving us.
3 tweaks away. Anatomy is the key.
Anatomy is the key.
Anatomy is the key. Anatomy is the key.
Anatomy is the key.
And the third, anatomy is the key. Every time, even when I teach surgery, things that look so simple, sometimes you have a problem. So anatomy is the key, and the technique also. So when, because it's like an algorithm. If you use the anatomy, you are using your common sense.
Yeah.
And then you are going to say, why should I use needles if I know the anatomy? And then you're going to use cannulas. And then you're going to obtain natural results.
Okay, Dr. Beut, Thanks a lot for being with us tonight.
Thank you to invite me. Merci.
Thanks a lot to our patient. Merci beaucoup. Thanks to everybody, the whole audience, live and on the web. Thanks a lot for your question. The next live show will be in the back-to-school period on the 4th of September. It will be in French on the eye and peri-eye zone. Thanks a lot for being with us. Don't hesitate to ask any question, and we'll try to answer it if we didn't have time to answer it during the live show. Thanks a lot, and have a good evening.